Good morning to one and all. So today's class will be on magnification, or might as well say as an introduction to magnification. As you're all aware of how you might have seen the use of certain magnification devices by a dentist, or you might have seen even in our department where there's a microscope that has been used for certain endodontic cases. So, what is this importance of magnification? Why it was introduced into dentistry, and why in endodontics and conservative dentistry it claims a very important. So, for many years, endodontists have tried to see deeper into the pulp chambers and into the very root canal spaces themselves. So, how the concept of magnification came into play is that if it's a possibility to see the canals, you can obviously treat, clean, and fill the canals better. So initially, a simple magnifying lens and surgical loops were the ones that had been. And we might think that microscope is a recent addition to our endodontic or in our dental practice, but no, it's been used in the medical field for over 50 years, and it's been introduced in endodontics in 1990s. Whereas in case of the Carl Zeiss company, it was introduced in case of otolaryngology, then in case of neurosurgery, and like I mentioned, endodontics in the year 1990s. But in dentistry, endodontists were the first one to introduce. Just to brush up with the rough history of operating microscope, it's just that in 1922, application for surgical procedures at the University of Stockholm. Then in 1982, you can see that in September 25th was the first clinical hands at the Harvard Dental School. Then in 1953 was when Carl Zeiss company marketed the first commercial binocular surgical operating. And in 1997, microscopic training was mandatory for advanced specialty programs in endodontics in the USA schools, USA in the United States of America, dental schools. So when we talk about magnification, before we jump into using a magnification device, whether it's a microscope or loops, there are certain few concepts of optical properties that we need to know before we start with the usage. Like I said, magnification. Magnification is basically where the image is increased by simply decreasing the distance between the eye and the object in question. Like if you need to see something more precise, or if you want to see something more detailed, what our normal tendency would be to come closer to it. When you come closer to it, you get a better vision. So that invariably gives you a magnified image in your in our eyes. So anything that can be viewed in a larger aspect is what magnification is, and to improve or to see in a better way, we tend to bring the object closer to us or closer to the eye, or that means the distance between the eye and the object is reduced. Working distance is primarily from our eye to where we are working. So that is the distance from the microscope objective lens to the point of focus. That could be anything. It could be the tooth, it could be the gingiva, it could be the finish line, anything in case of dentistry. So the distance should be sufficient. What we need to remember in case of working distance is that the distance needs to be sufficient to place the hand and the instrument comfortably between the microscope and the operating area, as depicted in the picture. You need to have a sufficient distance so that you have enough accessibility to the patient as well as your instruments, as well as that you will be able to see. Field of view is basically what we see, what we normally see with when we are using a magnification device or even with a naked eye. So field of view is basically like how it's depicted in the picture. So in case of the field of view, you can see the actual size is just of the mouth, and then as you grow closer, you can see that you cannot appreciate the outer aspect of the mouth, and we have gone into inside the mouth. And when you again further increase the magnification, you can see that, okay, we are focusing only on the first and the second molar. And similarly, again, when we increase the magnification, again, we can appreciate that we are looking only at the first and the second molar where there is an amalgam filling. So what is seen through the magnification device is what the field of view is. Depth of field or depth of focus primarily means the point of perfect optical focus where the sharp focus is maintained or where you can obtain a sharp image. Like in the first image, you can appreciate that there is a canal which is flooded with sodium hypochlorite, and you can see the bubbling action of the hypochlorite. So that bubbling action that we see is basically the depth of field or the depth of focus, and every other object around the image is blurred, whereas you can't appreciate the anatomy of the tooth as such. So that what we focus on, that is the depth of. Resolution is basically defined as the ability to differentiate between two closely positioned objects. So resolution and depth of field are basically inversely related to each other. The greater the resolution, the lesser will be the depth of field. Interpupillary distance is self-explanatory. It's basically the distance between the two eyes. Moving on to why do we need to use magnification in dentistry is that the human vision or the human eyes, there is a certain limitation. So the certain limitation is that the resolving power of the unaided human eye is only 0.2 mm, which means that if 2 points are closer than 0.2 mm, they will see it as 1 point. So when we apply that in dentistry, what happens is that the film thickness of most crown and bridge cements is 25 microns. That is 0.025 mm, or which is well beyond the resolving power of the naked eye. So operating microscope can raise the resolving limit from 0.2 mm to 0.006 mm, and which is a dramatic improvement. This is the classic image in which you would come across in most article, journal clubs, and presentations. There's a classic image in which we can see that the details on George Washington's face cannot be seen in detail. So this is what we see without magnification. A dollar bill which is seen in magnification. But if you look closer, that is the image A, which is in a magnification of 3x, then image B, which is in a magnification of 5x, and image C, which is a magnification of 8x, and D 10x, and E is 18x. You can see from A to E, the magnification is increasing, and you can see the square checks more clearly in B compared to A, similarly C compared to B, and D compared to C, and E compared to A. So the amount we view or the amount we see is dramatically different when you have a magnification device. So why enhanced vision is necessary in dentistry? Restorative dentists, periodontists, and endodontists routinely perform procedures requiring resolution which is well beyond 0.2 mm limit of the human sight. So crown margin, scaling procedures, incisions, root canal location, caries removal, furcation and perforation repair, post placement or removal, and bone and soft tissue grafting procedures are only few of the procedures that demand tolerances well beyond the 0.2 mm limit. In this image, we can appreciate, whereas this is basically in a veneer preparation, which means the preparation is concerned only with the enamel. So you can appreciate the finish line as the magnification increases. Whereas in 20x magnification, you can appreciate how the cord packer has been packed into the gingival margin as well. This is just to give you an idea of magnification. And the other procedure that can be done would be not just in endo, would be in case of scaling and root planing, which is mentioned, that is a preoperative image shown in A, then scaling at 8x magnification in B, and then root planing again with Gracie's curate, that is a higher magnification, and the post-operative view. So even with a 2.5x magnification, operator can make up to 50% fewer errors in routine dental practice. So the benefits of using any type of visual enhancement is that there's improved efficiency, improved quality of treatment, improved ergonomics, which means better posture, increased productivity, and obviously improves the stamina. In this image, we can see that in certain cases, if you're not able to visualize properly, we tend to bend towards the patient even more. So the more we bend, that's the amount of stress or strain that we tend to give our backs or the neck. You can see that in case of 0 degree, there's a pictorial representation just to show that in case of 0 degree, there is 12 pounds of weight that is around your neck. And as the degree increases, that is when you bend say to say about 60 degrees, like the last image as shown, the amount of weight which you will be feeling on your neck and back is quite extensive, and working like that for 8 to 9 hours is will obviously interfere with your practice in the long run. Moving on to the magnification devices that are available. The first one being the loupes, which is the most popular type of magnification used in dentistry today. While none of these systems provide neutral head posture, a well-defined loupe may significantly improve the operator working posture in dentistry that contribute to musculoskeletal disorders and contribute to clinical comfort. Well-designed loupes should enable a working posture of less than 25 degrees of forward head posture. Loupes range in strength from 2x to 5x and available in two basic styles. That is, you have the flip up and the fixed mount, or through the lens loop. Loupes are further divided into there's a Galilean system and there's a Keplerian system. A Galilean system provides a magnification from 2 to 4.5x, and it's a small, light and compact system. Whereas the Keplerian loupe system consists of a series of prism loupes which uses refractive prisms and are actually telescopes with complicated light path which provide magnification up to 6x. The only difference is that the Keplerian system, since it consists of a series of prisms, it can increase the magnification as high as 6x, whereas in case of Galilean loupes, you can have a magnification of maximum of 3.5x. Since Keplerian loupes consist of a series of refractive prisms, it tends to be a little heavy on the nose. That is one disadvantage of a Keplerian system. Then of course loupes with lighting, which enables a better. The advantages of loupes is that it is compared to a microscope, it is lesser expensive. That is, economically it is more affordable. Then it has a short learning curve. Then mobility from operatory to operatory is also possible, which means you do not have to work in a fixed position. Like you can, if you're practicing in any other place, you can easily carry it with. And then universal professional acceptance due to familiarity with the concept. Like even when you use it with the patient also tends to be more favorable with it. The disadvantages of loupes are a need for multiple oculars to change the magnification. The magnification is fixed. It's fixed. If it's 3.5x, it's only 3.5x. Whereas in case of microscope, you can always change the magnification to a higher grade. And the other disadvantage of loupes is that converging vision for the clinician's eyes, which is the same as with unaided vision and can be fatiguing during long hours. Like increasing weight of the oculars as magnification increases, which is in case of a Keplerian loupe system. Lack of a light source to bring illumination to be magnified. Through the lens loops or the flip-up loops. Like I said, there are again the Galilean loops which can be divided into through the lens or the flip-up loops. Through the lens is basically custom made, it's lightweight and has a wider field of view and lower maintenance. The disadvantage is that it can be used for only one practitioner, multi-purpose use, as in you cannot share it between two practitioners. And they are obviously, since it's custom made, it will be slightly more expensive. And again, as it's custom made, it takes a longer time to manufacture. The advantages of a flip-up loop is that it's adjustable angle of declination, multiple users, it has a faster delivery time and it's a lower price. The disadvantage is that it is a narrower field of view and may need additional adjustments. This is general guidelines for magnification strength about how to choose your loop. Or if you're a dental hygienist or for a scaling purpose, you can think of investing in something as with a magnification of 2.5x. Whereas in case if you're an endodontist or periodontist, you can think for a higher magnification of 3.5 to 4.5x. Moving on to the dental operating microscope, we shall start with it by learning the different parts of a microscope. As mentioned in the figure, you can appreciate that there is a horizontal arm, there's a counterbalance arm, there's a spring arm, there's a scope head, control unit, and the illumination light. And further, when we go into the components of the operating microscope, such as the one we have in our there is a brightness control, which means you can adjust the amount of light that comes through. That is, you can reduce it, you can increase it as well. Then there is a viewing tube, which is an inclined or a tiltable tube to permit an ergonomic treatment. And that viewing tube consists of the eyepiece which is close to our eyes, self-explanatory. Then you have something called as a magnification changer or zoom, which I mentioned earlier. In case of a microscope, you can work with various magnification. It is not a fixed magnification number. You can change from a low magnification to a high magnification or vice versa. And then you have the objective lens with a fixed focal length. The objective lens which is closer to the object, whereas in our case it would be the tooth or the patient. And the light, which is a coaxial illumination, which delivers an optimum light to the working area. Setting your interpupillary distance, there is a scale in which there's a scale in which you need to adjust to check your interpupillary distance. If this is also not working out, you can always consult an ophthalmologist who will also help you find your interpupillary distance, and it is fixed. It's most likely fixed for an individual. How to go about with the fixing of an interpupillary distance? That when you view through the microscope, you should be able to see it as a single image and not as a double image. When it's seen as a single image, that distance would be your interpupillary distance. If you are a spectacle user, you can adjust the eye cups in such a way that the entire field of view can be seen. That is viewing with glasses, screwing in the eye cups all the way, in which no silver lining is visible. And for people without glasses, you need to screw out the eye cups and adjust them for your field of view. It basically compensates with the distance between the eye and the objective lens. Between the eye and the eyepiece lens. Not the objective lens, between the eye and the eyepiece lens. This is what's seen in our department. This is what I meant about the diopter setting. So magnification, the value of magnification is basically calculated with the help of this equation that we see, where you can see that the total magnification, which is the Tm, equals to the focal length of the binocular by the focal length of the objective lens into the eyepiece power into the magnification. So if you have to calculate the magnification on your microscope, if you say, yes, it's just for your information. So the total magnification, if you need to calculate ever, this is given with an example. Like I mentioned, the parts of an operating microscope, apart from the body of the microscope, is that you have a supporting structure, you have the body of the microscope, which consists of the lens, the handles, the change in diopter settings, everything, and obviously also which supports the light source. The supporting structure, it is essential that the microscope be stable while in operation, yet remain maneuverable with ease and exceptional precision, particularly when used at high power. The supporting structure can be mounted on the floor, the ceiling, or the wall. As the distance between the fixation point and the body of the microscope is decreased, the stability of the setup is also increased. Floor mount is what we see in our department. Ceiling mount, you can mount it to the ceiling, it conserves space, but the microscope cannot be moved from one room to the other, which is the same situation in case of a wall mount. A table mount is primarily used in case of an educational setup. Body of the microscope includes the eyepiece, the binocular, the magnification changers, and the objective lens. Eyepiece, like I mentioned, the one which is closer to the eye, it has available in various magnification of 6.3 to 20. The end of each eyepiece has a rubber cup that can be lowered for clinicians who wear glasses. It has an adjustable diopter setting. Then diopter setting also adjusts for refractory errors and it ranges from -5 to +5. Binoculars is basically to hold the eyepiece. It adjusts the interpupillary distance, that is the distance between the two binocular tubes. Once the diopter setting and interpupillary distance are set, they are not to be changed until the microscope is used by a surgeon of different optical requirements. They come in different focal length and they are available in straight, inclined or inclinable tubes. The magnification changes, like I mentioned, in case of microscope, the magnification is not fixed and you can increase the magnification. It is available as 3, 5 or 6-step manual changes or power zoom changes, a series of lenses that move back and forth on a focusing ring to give a wide range of magnification. It is controlled either by a foot control or a manual override. Foot control allows the clinicians to adjust magnification and focus without taking the hand or eyes away from the surgical field. But what we have in our department is basically a manual control and is operated by the hand and not by a foot control. This is a skeletal diagram which you can appreciate where the eyepiece is, the eyepiece lens, that the magnification changes where the lens keep changing, and then the objective lens which will finally focus the objective lens is basically the nearest to the surgical field. The focal length of it determines between the lens and the surgical field, and it is available with focal length ranging from 100 to 400 mm. A 200 to 250 mm objective lens is always recommended. This is because there should be enough room to place surgical instruments and still be close to the patient. Coaxial illumination is basically illumination that is projected down through the same objective lens which is used for viewing, and there is no shadow that is created. It's more the simple way to explain is that it basically moves with you, which means there is no shadow that is created because of any other object unless you block the light with your own hand or instrument. So any change made in the microscope magnification will have no effect on the amount of light being projected from the microscope. The recommended light source can be powered by halogen or by xenon light, but most of them accommodate LED lights, and LED lights have an additional life compared to halogen and xenon light. Xenon lights are also incredibly good, but they are highly expensive and they do not have a their longevity is lesser compared to the LED lights. Halogen lights provide an artificial yellow light which is not ideal for documentation, and sometimes it tends to cure the composites also earlier. The prerequisites for the use of microscope in case of non-surgical endodontics would be rubber dam placement is a must, then indirect view is what we rely on. Whether it is a maxillary tooth or the mandibular tooth, you always rely on indirect view. The mouth mirror placement is very essential, and there's always some key instruments that rubber dam placement is primarily to get the contrast as well as a contrast in the working area, as well as it it does not fog the mouth mirror. So using operatory microscope and rubber dam is necessary when you're using an operatory microscope. To absorb the reflected blue light and to accentuate the tooth structure, it is recommended to use blue or green rubber dams. That's what I meant. Rubber dam gives a very good contrast. And the view through the microscope lens is the view reflected by the way of a. You need to rely completely on indirect vision. Key instruments is that you need to have the flexible mirrors, you need to have micro debriders, then you need to have reflective mirrors and flexible and flat shaft mirrors. The importance of magnification is that it also helps in documenting if a DSLR is also mounted with the microscope. The importance of documentation is that you can always show the patient before and after, as well as for publication purposes and for your record purposes. You can also educate the patient as well. If you have a documentation device and then you have a screen showing it live, you can always do a better patient education. Then the other purpose of documentation is primarily for educational purpose. In case of typhoid on teeth, you can actually show the whole class of class 1 restoration or the class 1 cavity preparation, application of base and restoring it with amalgam. The most appropriate operating position, it's a combination of the patient head position, then obviously the dental chair position, the microscope position, the surgeon position and the assistant position. Patient head position is that ensuring patient comfort during surgery is utmost important. There is no straining or torquing of head and the neck muscles. Occlusal plane has to be parallel to the floor for mandibular surgery, whereas in case of maxillary surgery it needs to be perpendicular, and head needs to be comfortably centered or slightly turned. The dental chair position, as you're all aware, the dental chair can be maneuvered in a variety of positions. The chair position should be slightly below the operator position for maxillary surgery, whereas in case of mandibular, it should be compared to the mandibular surgery. The microscope positioning is also. So in case of many endodontists, they prefer a ceiling mounted operating microscope. Suspension arm supports and positions the microscope in horizontal and vertical dimension. And inserting 135-degree inclinable coupler allows additional movements and more versatility. This is the selection of the binocular critical. Inclinable binoculars are the best ones. Inclinable tube provides the operator with additional postural comfort during long procedures but are comparatively expensive. Surgeon position should be that the doctor or the practitioner should be using an adjustable stool. The thighs have to be parallel to the floor. The arms relaxed and placed comfortably at the side. The assistant position is that there are normally, in case while working under magnification, there are 3 assistants. Whereas the first assistant, which is responsible for suctioning, which is usually seated. The second assistant passes the instrument's position next to the surgeon's dominant side, if a pen delivery system is used, and position across the surgeon, and the third assistant which is in charge of the video and the photographic functions. The law of ergonomics states that an understanding of efficient workflow using a microscope entails the knowledge of the basis of ergonomic motion. So the law of ergonomics is basically divided into 5 classes of motion. The class 1 motion where only your fingers move. The class 2 motion where your fingers and your wrist move. The class 3 motion is basically movement originating from the elbow. And class 4 is from your shoulder, and class 5 is that involves the twisting or bending of at the waist. So in this we can appreciate that in figure A, the finger is waiting for the file, and in figure B, the file is placed in between the fingers. Then C, the finger is capturing the file. This is basically with the help of a dental assistant. You can see in the image A that the elbow is rested at the stool support, then supported elbow rotation and instrument apprehension, then supported elbow rotation to working position. The circle of influence states that all instruments and equipment needed for a procedure are within reach of either the clinician or the assistant, requiring no more than a class 4 motion. In case of endodontic procedures are performed only with a class 1 and class 2 motion only, and the circle of influence, that is the design principles, places the oral microscope at the center and all the other things required within the circle. Maintenance is also very important in case of microscope. The microscope is as equally exposed to aerosols and splatter. So with the help of a plastic sleeve is always advised, as well as a lot of irrigants that we use can tend to discolor the metal, such as sodium hypochlorite. So it's always recommended to use a plastic sleeve on the dental operating microscope. Yes, that's all. This is just a basic class to an introduction to give you an idea of introduction to magnification. Thank you all for your patient listening.